Hello, my name is Dennis Cardone, and today we're talking about overuse injuries. My only disclosure, Chief Medical Officer of the Public Schools Athletic League. Overuse injuries are cumulative traumatic disorders, and they're common. 30 to 50% of pediatric sports injuries are overuse. Factors associated include early sports specialization, training harder, participating in sports year-round, and playing on multiple teams. More than 50% of adult sports injuries are caused by overuse. There are certainly physical and psychosocial benefits to exercise, so we should all be promoting exercise. These benefits include improved cardiovascular function, improved muscle strength and balance, improved motor skills, reduced anxiety and depression, community involvement, and also social skills. The definition of overuse injuries: microtraumatic damage to a bone, muscle, or tendon that has been subjected to repetitive stress without sufficient time to heal or undergo the natural reparative process. The picture on the left depicts a patellar tendon, and you see the tightly bundled collagen fibers. On the right, loss of collagen continuity, and you clearly see the collagen defects. So tendinosis is an overuse injury with recalcitrant pain with activity. Histologically, there are chronic degenerative lesions of the tendon and poorly organized and dysfunctional matrix. Remember, it's not a failed healing response. There's no acute injury or inflammatory phase. And important to also realize that there is an early histologic finding that goes along with tendinosis, and that's neovascularization. And that you could see even with bedside ultrasound, in-office ultrasound. The common tendons subjected to tendinosis: rotator cuff, patellar tendon, Achilles tendon, posterior tibialis tendon, and tennis elbow, the common extensor origin at the elbow. A common classification system for tendinosis is the Blazina grading system of tendinitis. Grade 1, pain only after activity. Grade 2, pain during activity that does not affect performance. And grade 3, pain during activity that does affect performance. In most cases, treatment is non-surgical, including modification of activity, eccentric strengthening in a physical therapy program, and other treatment and modalities with few controlled studies include hyperbaric oxygen, nitric oxide, such as prescribing low-dose nitroglycerin patch, sclerotherapy, extracorporeal shockwave therapy, and PRP, platelet-rich plasma. In recalcitrant cases and failed non-operative treatment, surgery can become an option. One thing important to remember in terms of randomized controlled trials is eccentric strengthening has been found to be as effective as surgery for specifically patellar tendinopathy. One overuse problem is overtraining syndrome that affects as many as 7 to 20% of high-performance athletes. What's interesting about overtraining syndrome is it's most common in sports where the body is supported by equipment or water, such as in swimmers, triathletes, cyclists, or rowers. Overtraining syndrome, there is an imbalance between excessively large volumes of training without adequate rest or recovery. There is a decrease in the performance despite regular training. And in the differential diagnosis, it's important to consider any type of illness, such as flu or virus. Does somebody have an anemia that you might see in runners? Dietary insufficiency or caloric intake insufficiency, and poor psychological preparation for training. Symptoms of overtraining syndrome, as you might expect, is a decrease in performance and a reduced ability to perform high-intensity exercise. Athletes often complain of persistent high fatigue, a decrease in their maximal heart rate, change in blood lactate variables. There may also be neuroendocrine changes, and changes in the athlete's self-reported indicators, including well-being, such as fatigue and quality of sleep. Many athletes will talk to you about elevated early morning heart rate, but this has not been validated. Reduced VO2 max, decreased testosterone or cortisol, change in mood state, and sleep disturbances. These are other factors that have also not been validated in overtraining syndrome. So what are contributing factors? A sudden increase in training volume or intensity, a heavy competition schedule, lack of periodization. And periodization refers broadly to training that is structured around periods of progressively loading training, stress followed by rest. Also contributing factors, monotonous training program, and stress level, whether it's related to their sport or activity or other stressors in life. The treatment for overtraining syndrome, not always specific, so the best treatment of all is to remove the athlete from their specific sport or activity, usually for a period not days but for weeks, so in most cases upwards of at least 2 or 3 weeks away from activity. Medications can be tried, such as an SSRI, and oftentimes it is a team approach between a physician and a psychologist. Prevention really here is the key. For example, playing sports only 8 months per year, playing for only one team, not playing the same sport more than 5 days per week, and also that training of periodization. Let's turn to running injuries. It is a very common pastime and sport activity. Runners have high rates of injuries. As many as 50% of runners are injured yearly. 25% of all runners are injured at any given time. And interestingly, when we talk about prevention and risk factors for running, there really is not good evidence-based information. There is some good evidence, possibly even strong evidence, for limiting total running mileage, more so in male runners. A common number that comes up when you look at the literature is 40 miles. So for runners who stay under 40 miles per week, much less likely to have some of these overuse injuries compared to running more than 40 miles per week. Other potential risk factors include a previous injury rate, running on hard surfaces, although when you look again at the literature, this has only been shown in females running on concrete and have not seen that in male runners. A pes cavus foot is a risk factor, more about the stiffness of the foot. Leg length inequality may be a risk factor. Orthoses, including off-the-shelf orthoses, may lessen the risk of stress fractures, but not related to specific anatomical variants. And where evidence is lacking is eccentric strength, biomechanics, specific running shoes, stretching, warm-up, psychological factors, and hyperpronation. Let's look at a case of a runner. Here's a 19-year-old sophomore cross-country track runner who presents with complaints of left hip pain for the past 2 weeks. Pain at the anterior hip, denies any trauma. She runs approximately 70 miles per week, which is very typical for a collegiate runner. No pain with walking except when going downstairs. No previous history of hip problems or injuries. She's had no menses for the past 3 months. She's not sexually active. She states that she eats a well-balanced diet, and her medical history is otherwise non-contributory, and she takes no medications. The examination of the right hip, there's full range of motion, both passively and actively, with discomfort at end range of internal and external rotation. There's no tenderness to palpation. And when you have the athlete perform a hop test, she does get discomfort when she lands on the affected leg, so a single leg hop test. A straight leg raise test is negative, and there's no pain with stress testing of the hip flexors. The x-ray that you see looks normal. Here is a coronal T2 MRI image, which clearly shows a stress fracture with bone marrow edema at the compression side of the femoral neck. So turning our attention to stress fractures, these are certainly common injuries in running athletes. As many as 10 to 20% of runners will sustain at some point a stress fracture. The predilection for stress fractures, certainly as you might expect, are in the lower extremities, especially the tibia and metatarsals. I've only seen one upper extremity stress fracture, and that was in a tennis player who was with a coach practicing for several days, a backhand, and had an ulnar stress fracture. So the pathophysiology of a stress fracture, it's a fatigue failure of bone. It results from accumulation of microdamage that occurs with repetitive loading. It starts in the areas of stress concentration, so there's a crack initiation, there's continued loading, which leads to crack propagation. Ultimately, the bone will fail, and there's a reparative biologic response that's dependent on the age of the athlete, the nutritional status, hormonal status, and potentially there's also a genetic predisposition. Stress fractures are classified according to high risk and low risk. With high-risk stress fractures, there's a delayed recognition of undertreatment that can result in prolonged recovery, fracture progression, non-union, surgery, and possible refracture. So the common high-risk stress fractures, the femoral neck, either the tension or compression side, the anterior tibial diaphysis, navicular, the Jones region, the metaphyseal diaphyseal region at the base of the fifth metatarsal, the sesamoids, the talus, and then you have your low-risk stress fractures. For most stress fractures, the pain can be insidious in onset, and then there are some where it's an acute onset of pain. Usually a history of some prolonged level of high activity or a recent increase in activity level, especially that a runner might say that they significantly ramped up their running program, either in terms of mileage, days, or intensity. Consider an insufficiency fracture or pathologic fracture if no history of repetitive loading. And on physical examination, there may be discomfort with range of motion of the affected area. There may be tenderness to palpation in the affected area, but one of the most important tests is certainly to load the area if you suspect there is a stress fracture. So for most stress fractures in the pelvis and lower extremities, the HOP test is a really nice screening test to perform in the office setting. If you suspect a stress fracture, absolutely imaging should be obtained. Should start with radiographs, realizing that radiographs may be negative, especially in the first 2 to 3 weeks, even with a stress fracture. And if radiographs are not conclusive, then the test of choice typically would be an MRI. Bone scans are rarely used in this day and age, and a CT scan also typically not used in the acute stage for stress fractures, but more for certain type stress fractures, such as a Jones fracture, for example, to check healing, or spondylolysis to check healing. Treatment principles of stress fractures really depends upon a high risk or low risk stress fractures and the location of the stress fracture. For example, with pelvic stress fractures, often no matter where the location is, they require 12 weeks of stopping activity, no impact or loading the area. The reparative process must succeed the accumulation of micro damage at the fracture site. So for most athletes, we take them out of their impact activity and what we call relative rest, have them do cross training, often bicycling, running or swimming in a pool. And if they can tolerate, depending on the type of fracture, weight bearing, then sometimes on an elliptical trainer. Absolute rest, especially for some of the more concerning stress fractures, they may have to be even non-weight bearing for a period of time. Bracing or orthoses, again, depending on the type of stress fracture. When returning back to sport or activity, think about technique modification to reduce risk of a repeat injury. And for certain stress fractures, such as the anterior tibial diaphysis, anterior tibial stress fracture, or Jones stress fracture of the fifth metatarsal, consider early surgical fixation. It's very important to get a good history in athletes who have stress fracture, including nutritional status, hormonal status, especially in female athletes, to see if their menses are regular or if they've significantly had decrease in the regularity of their menstrual cycle, or lost or have complete loss of their menses cycle. What medications are they taking or have they taken, such as, for example, prednisone. Red S, relative energy deficiency of sports. This is where, especially in, again, high school, collegiate athletes who just have a deficiency of their calories that they're intaking and set them up increased risk for stress injuries. For certain stress injuries with delayed healing, can try pulsed ultrasound or electric stimulation. Let's turn our attention to exercise-induced leg pain and compartment syndrome. So medial tibial stress syndrome, tenderness over the posterior medial tibia. Athletes will complain of a dull, achy sensation that may be at the end of an activity, in some cases during the activity, and oftentimes it's alleviated with rest. There are no neurovascular abnormalities. Imaging, not always necessary. Usually on exam, they will have tenderness to palpation in the region of that posterior medial tibia. It's diffuse tenderness. And a hop test will often be negative, although sometimes they may have some discomfort on impact with a hop test. If the diagnosis is not clear, certainly radiographs should be gotten, and then if necessary, an MRI as well. So an MRI classically would show increased uptake along the posterior medial border of the tibia. Here we see coronal views, MRI that show diffuse bone marrow edema and soft tissue edema without a clear fracture line. So the treatment of medial tibial stress syndrome, activity modification again, and here it's typically short-term, maybe even just for as short as 10 to 14 days, having them cross-train, avoid impact activities. You can try certain modalities such as anti-inflammatories, local phonophoresis or iontophoresis, ointments or compression clothing may help relieve some symptoms. If an athlete is significantly flat-footed or pronate, you could try an off-the-shelf orthoses. Can try a physical therapy program for strengthening of involved musculature. In resistant recalcitrant cases, can think about PRP, platelet-rich plasma, or extracorporeal shockwave treatment, ESWT. Surgery certainly has variable results, which would be something to go to in a very small percent of cases that are completely resistant to treatment. A fasciotomy at a deep posterior compartment with release of painful portion of the periosteum. Let's talk about compartment syndrome, exertional compartment syndrome. 4 compartments of the legs. The anterior compartment is involved in 70 to 80% of cases of exertional compartment syndrome. The posterior compartment, noteworthy is that it's less predictable surgical outcomes. The pathophysiology of exertional compartment syndrome is essentially not well understood. Evidence is unable to demonstrate a decrease in blood flow. When we do MRI of athletes, oftentimes we see some fluid uptake, edema within the involved musculature, but oftentimes it's not specific. Muscle biopsies, conflicting results regarding the role of muscle ischemia in generation of pain, and about 40% of people with exercise-induced compartment syndrome do have fascial defects. In terms of a diagnosis of exertional compartment syndrome, history is key. Athletes will present with a classic history of no pain at rest. They can usually predict how far into an exercise program where they will know exactly when their symptoms will come on. So reproducible exercise-induced leg pain, completely relieved by stopping their activity. On physical examination, it's usually a normal exam, sometimes some discomfort with passive motion, but not typical, and have a negative hop test to rule out any type of stress injury. The workup of a compartment syndrome at NYU, sometimes we do order a pre and post exercise MRI where they get on a have an MRI, then get on a treadmill and have a second MRI after induction of symptoms. And again, that could show sometimes some edema, fluid in the involved musculature, but not necessarily specific. The true workup for compartment syndrome is intracompartmental pressure testing. And the things to remember are resting pressure, what's positive resting pressure over 15, immediate 1 minute post-exercise, a pressure of over 30, and after or at 5 minutes after exercise, pressures greater than 20 at 5 minutes and greater than 15 at 15 minutes. The treatment of exertional compartment syndrome is, to say the least, very difficult, and probably because we don't necessarily understand well the pathophysiology involved. So the non-surgical treatment, and we've tried everything certainly for it in terms of physical therapy, modification of activity, compression, clothing, and really nothing has been shown to have any significant effect on the pressure, and usually most athletes will say that it's not helping their condition. Anti-inflammatories also have proven ineffective as well. If you look at some of the studies over the past few years, there have been some positive studies using botulinum toxin, and there was a really small study looking at running form and having runners midfoot, switching to a midfoot and forefoot running posture, and this did help with regard to exertional compartment syndrome symptoms, but it really was a very, very small study. For most athletes with exertional compartment syndrome, if they want to continue their activity and are significantly disabled by the exertional compartment syndrome, surgery becomes the treatment of choice. So it's indicated for athletes with appropriate clinical presentations, confirmatory pressure measurements, and again, those that are unwilling to modify or give up their sport. But realize that surgery outcomes are also not a home run procedure. Symptoms are likely often multivariable. There really have not been any good studies directly comparing operative to non-operative treatment options. Surgery appears to be successful in about 80% of cases for the anterior compartment. For the deep posterior compartment, the success is lower, around 60%. And some of the more recent studies have found that releasing less compartments, number of compartments, is better. So a single compartment release even has been shown to have some of the best results. Occasionally, an athlete can present with a localized fascial hernia, and this hernia can become symptomatic because of chronic exertional compartment syndrome, a compressive neuropathy, or ischemia of the herniated muscle tissue. The hernia is typically at the exit of the superficial peroneal nerve, or one of its branches, is common in chronic exertional compartment syndrome. The cases that I've seen have been distal, at that distal lateral aspect of the leg. The treatment, if they're asymptomatic, no treatment is necessary. You can try activity modification. I have had some athletes who have had some improvement of some symptoms with support, compression, clothing, such as support hose. And then the results of fasciotomy here for the localized fascial hernia is actually quite good. Other causes of exercise-induced leg pain, think about peripheral neuropathy, especially a superficial peroneal nerve, which is a branch of the common peroneal nerve, most commonly compressed as it exits the deep fascia to become subcutaneous. It can become compressed by muscle herniation, fascial edge, or subject to repeated traction by recurrent ankle sprains. On exam, activity-related pain, neurologic symptoms in the distal third of the leg or dorsum of the foot or ankle. No weakness because innervation of the peroneals is proximal to the site of compression. The treatment here is a surgical decompression in some cases when necessary and symptoms are recalcitrant otherwise. Another overuse injury is sports hernia, otherwise known as athletic pubalgia. This is an overuse type syndrome, overuse injury, usually in higher level athletes. Extension, abduction of the leg with eccentric contraction of the adductors causes stress of the rectus and possible tears of the transverse fascia, rectus muscle, and/or adductor magnus origin. Microscopic tears or avulsion of the internal oblique muscles. So usually the history is significant for chronic pain, discomfort, especially with activity in that region. But many of the studies have shown that with modification of activity usually for even as much as 2 months with an aggressive physical therapy program, strengthening of the hip flexors and adductors and abdominals can significantly improve these symptoms. For the ones that are resistant to therapy. Sometimes a CT scan will be obtained to look for further evaluation for a sports hernia. If it is suspected, we typically send this to a general surgeon who's familiar with a sports hernia. Osteitis pubis, another overuse injury. Athletes will present typically with localized pain in the groin, in the midline. They're tender to palpation on that symphysis pubis. We have a loss of flexibility typically and a dull aching pain in the groin, especially aggravated with activity, and pain that will get sharp with strenuous activity. The treatment, similar to athletic pubalgia, often physical therapy, aggressive strengthening of hip flexors, adductors, and the abdominals will make a significant difference. It's common to see changes related to osteitis pubis on x-rays, and athletes are asymptomatic. In general, groin pain in the athlete, there are many diagnoses such as stress reactions, athletic pubalgia, osteitis pubis, rectus abdominal strain, and in most cases across the board, again, some modification of activity for about 6 to 8 weeks with aggressive physical therapy will cure most of these problems, and that's why oftentimes all these problems will get lumped into the diagnosis of groin pain in the athlete. No talk on overuse injuries would be complete without at least mentioning patellofemoral syndrome. If you have a sports medicine practice, this is by far one of the most common problems that will be seen in the office setting. Up to 40% of all knee problems presenting to a sports medicine office are patellofemoral syndrome. Females, compared to males, 2 to 1 affected by patellofemoral syndrome. The causes of patellofemoral syndrome: overuse, patellofemoral alignment, and trauma. Where is the pain coming from? Activation of nociceptive fibers in the subchondral bone, synovium, retinaculum, or local small nerve endings. Remember that the hyaline cartilage has no nerve endings. So this is a repetitive injury. High-frequency overload delivered to a malaligned extensor mechanism yields persistent, debilitating, unremitting pain in athletes in general, especially in runners. Probably another problem that we don't completely understand because oftentimes it is very stubborn and resistant to treatment. The history for patellofemoral syndrome is classic. It's usually localized pain at the anterior aspect of the knee, although some athletes will complain of pain at the posterior aspect of the knee, usually aggravated with activity, and certainly all activities that are quadricep or anterior knee dependent, such as squatting, kneeling, lunging, going down stairs, running downhill, or explosive activities in general are classic aggravators of the problem. Remember that some athletes will complain of locking sensation, but it's really a pseudo-locking where it's just the patellar is catching. They'll use the word locking, and that's why it's so important to take a further history when they talk about locking. But oftentimes it's more about the patellar catching and not true locking of the knee. When performing your examination for patellofemoral syndrome, look to see if there's any atrophy of the muscle, symmetry compared to the contralateral side. What does the alignment look like? And it's also a good idea to always look at the individual barefoot to see if they are flat-footed or overpronating. Palpation will also reveal tenderness at the distal poles and medial pole of the patella. It is also not uncommon to find a plica that's tender, especially along the medial patella. Physical examination of patellofemoral syndrome. Positives include a positive patella grind test, a positive quadricep inhibition test, obvious weakness with a single leg squat test, where there usually will be a valgus moment of the knee and also see shaking of the lower extremity while going into that partial squat position. When symptoms are persistent, doesn't necessarily have to be at the first visit. Imaging is worthwhile to get, including your typical knee views, a sunrise or merchant view. a lateral radiograph of the knee, and knee flexion views with the patient PA weight-bearing view with knee flexion at 30 degrees. When symptoms are persistent and recalcitrant to treatment, then an MRI is worthwhile, especially to look for any osteochondral injuries. The treatment of patellofemoral syndrome, there is a high rate of spontaneous recovery for most a course of home exercises or formal physical therapy for strengthening of quadricep, hip abductors, gluteals, and core makes a big difference. The patient should be very active in their role in treatment. It may take not just days, but several weeks or even several months for full resolution of symptoms. So it's important to continue to reassure and motivate patients to stay with their exercise program. Most athletes, patients can continue doing their exercise program with some modification. I try to have patients avoid deep squatting, kneeling, and lunging, and things such as box jumps, which are very irritating to the problem. When symptoms are persistent, sometimes can be worthwhile to also prescribe an off-the-shelf orthoses, especially if they are flat-footed or pes planus or overpronating. This can help. You can try bracing or taping, such as McConnell taping, or some type of patellar stabilizing bracing, and certainly the evidence for any of these interventions is mixed at best. For significantly recalcitrant symptoms, have tried viscosupplementation, and again, there's limited data supporting using these gel lubricant type injections for this indication. Let's look at some x-rays together and look at some other overuse type injuries. Here's an 18-year-old collegiate soccer player with chronic refractory bilateral groin pain. And when you look at the x-ray AP of the pelvis, you can certainly see delucency at the pubic symphysis with some sclerosis in the same region. So I would certainly think of an osteitis pubis, and I'll also think about some type of bony stress injury. So the same athlete, when you look at the MRI, now you can clearly see on this T2 weighted image, coronal, you can see the bone marrow edema, and you can also see a stress fracture line. So here's bone marrow edema and stress fracture at the pubes. Here's an x-ray of the elbow, and you look at the medial epicondyle, you can see the increased space between the increased space consistent with an apophysitis or a little league elbow. Here's a radiograph of a gymnast's wrist, and you can see the widening and sclerosis at the distal radius physes. This is an avulsion injury at the AIIS, consistent with a rectus femoris avulsion apophysitis. Here's a radiograph of the ulnar bone, also here showing a stress fracture. And as we spoke about earlier in the talk, I've seen this injury in a tennis player who was practicing backhand after backhand for several days in a row, a stress fracture of the ulnar bone. Here's an oblique x-ray of the lumbar spine depicting a spondylolysis at L5. This AP of the pelvis shows an apophysitis in a young athlete when you compare the left iliac apophysis compared to the right side. This is a good picture of Achilles tendinosis. You can see thickening of the Achilles tendon on this MRI view with increased intrasubstance signal. Some top testing facts to take away from the talk. The tibia and metatarsals are frequently affected with stress fractures. Stress fractures result from crack propagation that exceeds bone's reparative biologic response. High-risk stress fractures usually involve the tension side of the bone. Medial tibial stress syndrome is responsible for up to 15% of all running injuries. The anterior compartment is most commonly involved in exertional compartment syndrome. The diagnosis of exertional compartment syndrome can be made if athlete has both reproducible exercise-induced leg pain and immediate post-exercise intracompartmental pressure greater than or equal to 30 millimeters of mercury. Treatment of athletes with exertional compartment syndrome who are interested in returning to sport is surgical release of the involved compartment. Tendinosis is a soft tissue injury considered a failed adaptive response. Remember the Blazina grading system for overuse type injuries. And in terms of randomized controlled trials, eccentric exercises are as effective as surgery in the treatment of patellar tendinopathy. So important to remember is that overuse injuries are common.